This is the third in our Pathways Breast Cancer Survivorship webinars, Genetics and Breast Cancer, Learnings from the Pathways Study and Clinical Practice. Before we begin, I want to share that the slides are on the website, and Virginia is going to put the link to that in the chat. We also have a live transcript captioning available. The chat is view only, so you can look for resources there, but we want you to use the Q&A function to ask questions, which you can do at any time, and then we'll have time reserved for that at the end. The webinar is recorded, so the link will be sent out to everyone who registered, and it will be available on our website. And the webinar is going to last about an hour, but we may stay a little bit longer to answer more of your questions. So I'm Leanna Hartmore, I'm your moderator, and I'm Programs and Communications Director at Zero Breast Cancer. At Zero Breast Cancer, we've spent 28 years bridging researchers and communities to create educational resources for kids through adults to reduce the risk of breast cancer and support survivors' health and wellness. We're starting a health and wellness coaching program now too. So sign up for emails for more information about our resources and programs. Virginia's putting the link in the chat. First, I want to give a shout out to our Pathways Survivorship Study Community Advisory Board, which is facilitated by Zero Breast Cancer and a team at Kaiser Permanente, Northern California Division of Research. The Pathways Study is a prospective cohort of women diagnosed with breast cancer, and its CAB is made up of Pathways Study participants and breast cancer advocates. They give input on research priorities, community education, including giving input on this topic and slides that are shared today. So you can learn more about the Pathways Study at the link in the chat. Our first speaker is Christine Ambrosone. Dr. Ambrosone will be giving the first presentation. She's a distinguished professor of oncology at Roswell Park Comprehensive Cancer Center. She's been a collaborator on the Pathways Survivorship Study since its inception. I'll pass it on to Christine now.
Hi, everyone. I'm very happy to be talking to you today and participating in this workshop, and looking forward to the hour. So I'm going to share my slides, hoping everything goes well. Are we on?
Yep, good job.
Okay, all right. Okay, so I'm going to be talking a little bit about the role of genetics in cancer risk and outcomes, particularly in relation to the Pathways Study. I've been interested in this field my whole career, really, wondering why people with similar exposures, some people will develop cancer and others not, and trying to figure out that link between cancer susceptibility and environmental exposure. So we're going to talk a little bit about that today, give you kind of an overview, and then a little bit more about what we're doing in the Pathways Study. So we know quite a bit about what causes cancer, and one thing we really know is it's multifactorial. There are very few cancers where there's primarily one risk factor and one exposure. Good examples are smoking and lung cancer, but even among smokers, there's still other factors that play a role. Probably the biggest risk factor for cancer, particularly breast cancer, is aging. The older we get, the slower our cells get at fixing damage, and the more likely we are to accumulate exposures, and that could ultimately lead to cancer. Exposure to carcinogens, of course, risk factor for many types of cancers and for breast cancer. There's been a lot of interest in that. The Long Island Breast Cancer Study was probably one of the first that really tried to dig deep and understand those potential relationships. But as I'm sure many of you are aware, it's very hard to nail down through epidemiologic studies how any exposure to the environment may impact our risk of cancer, because we move all over the place, and we don't really know what time periods would be important or how that exposure occurs. There are certain cancers that viruses play a role in etiology. Radiation, one great example, well, bad example really, of radiation in relation to cancer was the bombings in Japan in World War II. And it was not women who developed breast cancer from that exposure, but girls who were about 12 at that time of the exposure. So when the breast is maturing and growing, but radiation is a key factor in cancer etiology. We're learning more and more that lack of physical activity is a big risk factor for many cancers. And this isn't necessarily being a marathon runner or working out really hard a lot. Any kind of movement is better than none. Alcohol consumption is associated with increased risk of cancers, including breast cancer, obesity, many hormonal factors, dietary factors. This is the reason that Dr. Cushy started this study, to understand the role of nutrition and dietary factors in breast cancer outcomes. We're learning more and more, but we still have quite a bit to learn. And then we all know family history of cancer, particularly for breast cancer, will increase risk. So where does genetics come into this? Well, as we think about family history, one factor that can come along with that for breast cancer and ovarian cancer are these rare inherited genetic mutations. I'm sure many of you are familiar with the BRCA1 and BRCA2 genes. And here, probably about 1 in 500 people in the general population carry these mutations, but they can put people at much higher risk for breast or ovarian cancer. There are other genes that are not as rare, and they don't confer the same amount of risk that those BRCA genes do, but these are P10, ATM, PALB2, and CDH1. And these are involved in cell cycle DNA repair. So there is available genetic testing for these and other high-risk variants, and Leslie's going to be talking about that in the next presentation. But I want to talk about more common variants that can also increase risk, and especially combined together or put together with environmental exposures. So a good example of this, and I mentioned it before, is we know that smoking causes lung cancer, but not everybody who smokes the same amount is going to be diagnosed with the disease. And we think part of this is differences in how our bodies and our cells respond to carcinogenic exposures. So especially like tobacco smoke carcinogens, they have to go through pathways of being activated so that they can then damage cells. So we vary in how we activate those carcinogens, how we detoxify them. If there is damage, our DNA is very good at repairing itself. And again, there's variability there. So in many, many ways along that path, there are differences in how we ultimately will be affected by exposures. When I started getting interested in this field, I found this in a textbook from 1956, Biochemical Individuality. Every individual has his own inborn metabolic characteristics. Every application of biochemistry, I'd say a lot of cancer research, to human beings must take these differences into account. And all diseases such as cancer, arthritis, heart disease, etc., are related to biochemical individuality. And it's taken us a really long time in epidemiology to catch on to this and to try to figure out how our individuality can play a role in our cancer risk. Well, how does this occur? We've got lots and lots and lots of strings of DNA in our bodies, and this DNA makes up genes that encode what the proteins or the enzymes should do. And it's really the instructions for our cells, our DNA in the genes. And there are these single nucleotide polymorphisms, we call them SNPs, that are little differences in the coding between different people. And this can change the actual coding part of the gene or the promoter, so what turns it on, what turns it off. And this variability can range from 1% up to 50% of a population. And I put this picture of the faces because we're all humans. Most of us all have the same facial features, but we look a lot different from each other. And this is really based upon polymorphisms in genes that kind of determine our hair color, our skin color, the shape of our faces, our eye color. All of these polymorphisms make us look like who we are. And this is the same metabolically as well. So I get really sick if I take codeine. I know that this is a polymorphism in a gene that activates that drug. And some people have it and some people don't. And as you think about our exposure to carcinogens, or how we handle dietary factors, how we process, everything along those pathways, there's variability in these metabolic pathways. And this includes response to exposures associated with cancer, what increases risk as well as what reduces risk. So we started studying these polymorphisms as a field probably 1990s, I'd say. And at first we started looking at very specific genes. Okay, we know that this protein, this gene, activates tobacco smoke carcinogens. So does variability in this particular gene put people at differential risk? And we call this the candidate gene approach. And we did that for quite a bit. Unfortunately, in our epidemiology studies and those with genetics and risk factors, we don't always replicate these findings, but they're some pretty solid clues along the way. Much later, people started this genome-wide association study. So by this time, the human genome was mapped, and we knew where, how you could look at DNA at different places. And a genome-wide association study looks at all of our DNA, and it tests for polymorphisms or SNPs that are associated with risk of disease. So you compare people with a disease to people without. This takes thousands and thousands and thousands of study participants. And I'd like to mention here, for those of you who participated in the Pathways study, if we are looking at genes, these are the types of genes that we're looking at, not any that we know is going to be putting people at risk. If you have that variant, you should go for genetic counseling. We do not look at any of those. This is purely for research and not for any clinical testing. So I think for cancer risk, the promise of trying to find these single variants that are going to increase risk, it was really limited because, as I said earlier, cancer is so multifactorial. There are factors that are going to increase risk and then factors that are going to decrease risk. And you put those all into the package along with our genetics, genes that put you at risk, genes that reduce your risk. These single SNPs popping out as, aha, this is what's going to increase breast cancer risk. Pretty unlikely. But I think there's more likelihood of finding genetic variants in populations if we know what the exposures are. So, okay, here's people who smoke compared to people who don't. What polymorphisms here are going to make those people who smoke at higher risk for lung cancer? And this possibly is going to give us even stronger data if we're looking at people who receive chemotherapy, if they received all the same drug regimen. The people who say have toxicities, do they possess specific genetic variants as opposed to people who don't get those adverse reactions to it? This field we're still working on this. We did candidate gene approach in relation to treatment outcomes, but then also GWAS studies. And in the Pathways study, we did a GWAS, and Dr. Cushy was the PI of this, and Shen Zhu and Song Yao from our place at Roswell Park took a lead in analyzing these data. And overall, there were no SNPs that jumped out as being associated with survival outcomes. But when they looked at just women who were treated with anthracyclines or Herceptin, a SNP in this gene, UACA, appeared to be associated with outcomes. Now, this gene helps cells escape the killing effects of chemotherapy. And so this makes sense. Now, when we have one finding, in our field, we say it's not the first study, it's the very last study. We need to see these findings over and over and over again in different populations done by different investigators. And when we see a whole big bulk of results like that, we can say, yes, maybe this is true. So we need to do more work in this area. One very promising area that people are looking at now using this GWAS data are looking at polygenic risk scores. So this is, you've got hundreds or thousands of genetic variants, and look at those all together, comparing to people with the disease or the outcome compared to those who don't have it. And you put together these polygenic risk scores that can be associated with outcomes. So it's the cumulative effect, and it estimates risk with those genotypes compared to risk in people with different genetic makeup. Again, this is not causal. This is just kind of a susceptibility, but I mean, if this is thousands of genetic variants, the odds of any of us having exactly those is, you need thousands and thousands of people to be able to see these associations. So in the Pathways study, colleagues working with Song Yao in our group calculated polygenic risk score for bone density. And then, so that was kind of the genes are predicting your bone density, not actually from scans. And looking at how that score is associated with later fracture risk in women who take aromatase inhibitors, because we know that this endocrine therapy, which is used to treat hormone receptor positive breast cancer, women on these aromatase inhibitors do have a higher risk of bone loss and osteoporosis. And in this study, genetic estimates of density were associated with fractured risk. A more recent study that Peter Fiorico, a student working with Song Yao and I in our group, has looked at genetically predicted metabolic traits in relation to outcomes. So this is not measured cardiovascular disease or not measured hypertension, but cardiovascular disease that's predicted by these polygenic risk scores. And these were associated with breast cancer outcomes in the Pathways study. So my take-home message here is genetic susceptibility is not deterministic. There are multiple genetic and environmental factors that may increase or decrease cancer risk, and it's the combined effects of these. So I've been interested in looking at genetics more to help understand these relationships between exposures and disease outcomes. If some people are more susceptible, then do we see clear relationships between the exposures and outcomes? I think most important for all of us to remember, This helps research, this helps us understand cancer etiology and cancer outcomes. But the most important thing to look at are prognostic factors that we know have clear effects on cancer outcomes. And for breast cancer, many other cancers we've been studying, you see it again and again and again, that exercise and physical activity reduce risk of cancer and also improve survival outcomes. And again, we've seen these relationships just looking at people who are sedentary, who report that they don't do anything, they barely walk around, to people who are not sedentary. We do see these same protective effects. So any message you want to take home from this is try to keep moving if you can. With that, I thank you. I'll end here. And my understanding is we're going to be taking questions at the end.
Thank you, Dr. Ambrosone. So Dr. Leslie Manace is a practicing medical geneticist at Kaiser Permanente Oakland Medical Center Department of Genetics. She's also Kaiser Northern California Regional Director for Precision Medicine and Genomics and Assistant Chief for Regional Genetic Screening and Tracking. So I'll pass it on to her.
Thank you. You can hear me okay? Should be coming in okay. It's such a pleasure to talk with all of you. I only have time to really give you an introduction today and sort of just define some of these key words, but I'm really looking forward to the question and answers as well. So I have no other relationships to disclose. And everything that I kind of talk through, I just want to set up against this backdrop, which is that it's really this incredible innovation around genomic testing. So DNA analysis and genomic clinical testing that is driving my whole field. So it's outstripping Moore's law, which you may know about in the electronics space and in our computing kind of world. We are really moving even faster than Silicon Valley, computing and electronics. So it is a runaway train, and we on the medical side are, keeping up with updates on a weekly basis that are really changing the practice of medical genetics, which is really taking care of individuals and seeing how all of this information relates to one person's risk and their care. So just to pose this kind of a perspective of how fast this is changing. Progress in science depends on new techniques, new discoveries, and new ideas, probably in that order, is maybe a way of phrasing it that you haven't thought of. But in this case, this is really how this field is being driven. So originally, we started, a number of decades ago, being able to evaluate genes on a single gene basis, where we're zooming in on one of our around 25,000 genes that we all carry that are instructions for something and working in the body. And we would use these techniques to really focus on, one or two genes at a time. Then we had a new technology where we could look across your chromosomes, which contain all of your DNA that you've inherited from your parents and new variations that are unique to all of us. And the really key technology for you to know about is something known as next generation sequencing. So this allowed us to look at many genes at the same time on the scale of hundreds or thousands of genes in one test in the same or even faster time frame that we used to look at only one gene. And it's at the point where we can even look across all 5,000 genes that we think have something to do with how the body works and are connected to specific diseases on a very one-to-one, a little more deterministic way than you were learning about just before me. So these are connected to actual genetic diseases. And we're moving into something known as whole genome, where we're not just looking at the DNA, but we're looking around the genes and at what the DNA codes for, which is RNA, and the proteins that are made from the RNA. And so we're really looking at a much bigger picture than we have ever before. So again, just something to kind of set this against is this time frame of, back when I was in high school, really like getting excited about DNA sequencing and being interested in moving into genetics. And then as I was in medical training, the excitement of the human genome being mapped for the first time. GINA is the Genetic Information Non-Discrimination Act. And so that was the first federal law protecting people against information discrimination. For having that predictive information in their hands, there are some protections so that it is advantageous to have the information and not a liability. And then as going from a multi-million-dollar project of the human genome down to a $5,000 genome just a few years ago is really how fast this is moving. This is something that you could have an entire seminar just on this one slide, but really the idea that we've been more reactive in medicine up till now, where we typically wait for signs and symptoms in order to detect and deter disease development. What we're moving into more and more now is just getting more and more, we say, upstream of all of those problems and being able to define someone's risk. And we'll talk about genetic risk, but like we just learned about, there are lots and lots of different factors. And then having earlier and earlier detection so that you can actually modify how you're presenting with diseases, ideally even preventing completely, and really having an impact on overall health. This is something I just want you to have this kind of visual in mind of what I think about in medical genetics. It's a very unique set of principles that come to bear on medical genetics that's a little different from other medical fields. There are some aspects that are very unique, and there are, of course, some things that overlap with other medical fields. But one big part of it is this whole center part of this diagram has to do with the genetic testing itself. So the validity and quality of that genetic testing is one of the bedrocks of my field, and more so that a lot is really just based on the testing to start with. Previously, we had to do a lot of diagnoses just based on how someone was presenting, and we didn't have the advantage of confirming a DNA mutation as much. But nowadays, we are relying on the testing more and more. So that's a big central part of the field. But then as you move out, you think about this concept of utility, and you can see all of these components of utility. And then cutting through all of it is something that we refer to as, we abbreviate it as ELSI, which is ethical, legal, and social implications. There are very specific ethical, bioethical considerations when it comes to genetics, and specifically eugenics, and historical factors that we really need to keep in mind and have a very responsible approach to how we conduct both research and the delivery of medical genetics care. So kind of juxtaposing the talk you just heard against mine, what I'm always thinking about as a physician geneticist is what I'm seeing in terms of what is going on for someone due to multiple factors, including some of those being genetic, or is it actually due to a very strong single DNA change, or we used to say mutation. We use the term pathogenic variant nowadays, but meaning something that causes disease that is a single typo in the middle of a gene, or like I was mentioning, around genes and in different areas of our genome, that is a very, very strong deterministic kind of a force in causing a particular clinical issue. In the case of cancer, like we're focusing on today, of course, we're thinking about cancer risk and developing cancer. And so what we work with in our field is that we're interfacing with primary care and specialty care who are working with either, in this case, somebody who wants to be proactive and they're concerned about their family history, but they themselves have not been affected with cancer. And this would be hitting more primary care versus somebody affected with cancer moving through medical, surgical, radiation oncology, and the cancer care specialties. And so we are interfacing with these other specialties in order to best educate them and their patients on what they need to be concerned about and next steps. So by far, most cancer is due to multiple factors, some of which are genetic, and like you heard about at the end there, multiple genetic traits or differences like polygenic in the sense of polygenic risk. And only a smaller percentage are due to a very, very strong single mutation. So for breast cancer, it's about 10 to 15%. It depends on the cancer type, what percent it is. For rarer cancers, that number does grow. And for more common cancers, sometimes it goes down a bit, even closer to 5%. And so again, my field is all about advising these other specialties and patients on what they need to be looking out for to distinguish between the majority of cancer being something that's due to multiple factors versus something where someone was actually born with a mutation that's in every cell of their body and predisposed them to the cancer, and for whom we have different care guidelines in order to hopefully better screen and prevent the cancer completely. Or if it develops, we do have some different treatments that may apply to them. And so really important to decipher between these. So you have your more, we call it more a common complex cancer would be multiple factors, including some of those being genetic. When you have familial breast cancer, there is more of a pattern, a little more than is expected just based on the epidemiology of breast cancer, which is unfortunately extremely common as far as cancers go in the top 5. And so many families have at least one, member affected. However, there are some families where it just seems to be a little more prevalent and in a pattern of being passed down on one side of the family. And that's kind of an in-between place. But when you move into what we call hereditary predisposition, then you've moved into this broken out pie chart here of all these genes that could have a single change in them that are actually causing this very high risk, and that people really were born with that risk. And so there is sort of a timing of when that affects them over their lifetime, but their lifetime risk is much higher than the general population. And so in terms of being able to identify those people who have this very different kind of a picture of much higher risk, different screening and care would apply to them. It's a logistical problem right now where we have all of the technology available, but very few of the actual workflows in place and bridging between your standard care right now and getting to a reality where people have access to their genomic information. We have quite a ways to go. We have definitely started out quite decisively on that journey. And Kaiser Permanente is in a really good position to develop this, because we kind of think of things in more of a public health standpoint, because we really have an incentive to identify risk and prevent disease, as opposed to the old reactive model of healthcare. And so an example of us starting out on transforming the model is that what I've helped to oversee is that we give access to this genetic testing itself to find those gene changes right at the point of care, instead of requiring that people are referred out to genetics and come back in to their cancer care. So starting to innovate when it comes to people affected with cancer, and then having that ultimately benefit those well people who are not yet affected by cancer, but who can benefit from, as I say, kind of these new workflows and new infrastructure that we have to build. And there's something to just keep in mind, which is that the CDC has prioritized 3 conditions as being on a public health scale. So they're the most common of the predispositions in my field. And the very first is hereditary breast and ovarian cancer syndrome, so far just associated with BRCA1 and BRCA2. But someday we may discover that there are other genes that are correlated to this condition. There's another cancer predisposition condition known as Lynch syndrome, predominantly endometrial and colon cancer, and as well as others in that syndrome. And then the other condition is not a cancer predisposition, it's familial hypercholesterolemia. So again, being born with and over lifetime having a much higher LDL cholesterol than the general population. So on the horizon is you saw in the diagram just about getting closer and closer to early proactive risk identification and early detection. Something that you may be seeing some press about is what's called cell-free DNA testing, where you're actually looking at bits of DNA that are floating around in our blood, and we've been able to pull that out from the background. So you sort of think of it as like kind of 1 in a million. The background is all your regular DNA. And then this different DNA would be, for example, if there is a tumor somewhere, it's actually spitting out abnormal DNA. But it's still very, very infrequent compared to all your other DNA. So being able to find that, there are some tests that are starting to have some promise that way. It's not quite ready for use in standard clinical practice, but it's starting to be used in places such as monitoring after treatment for, let's say, a blood cancer. Oncology is starting to use this to monitor for, recurrence. And so there are some places where we're just starting to familiarize ourselves with and let this science develop more. It's not quite ready for just a prevention for someone who's well with no symptoms or any findings on imaging quite yet. You've all heard about, of course, the advent of artificial intelligence and machine learning. We have shown in this paper that being able to distinguish breast cancer in mammography is well suited to machine learning. And so there are going to be some immediate advances that we see with, I would say, with some of the detection diagnostic areas would be where you maybe start to see AI starting to really assist us. And then you heard a bit about this concept of the polygenic risk score, that all of us have lots of little variants and some have more than others, and that might just adjust our risk slightly and kind of change how we should be screened and taken care of, even if we don't have one of those rare, strong hereditary predispositions. And then what we call pharmacogenetic testing has to do with, based on the actual aspects of the tumor, genetics, which are totally distinct from the rest of our body, as well as some aspects of how we break down drugs. What are the best matches for, especially in the context of our talk today, like chemotherapy and adjuvant endocrine therapy that are the best suited to treat and prevent any relapse of cancer. So, as you can see, lots of logistics, much more than, time than would need to be devoted to explaining all of that. But I wanted to just give you a taste of, what we're building, the first steps that we're taking, and how we're really translating all this research into improved care.
Thank you so much, Dr. Manace. So we're going to have our Q&A session, and Dr. Larry Kushi is going to be joining us. He's Director of Science Policy at the Kaiser Permanente Northern California Division of Research and leads the Pathways Study. So please put your questions in the chat, in the Q&A section, and we will address them as they come up. So first, we have a question that came in ahead of time. So how can we use this information to prevent breast cancer in future generations?
Mm-hmm. Mm-hmm. Yeah, that's really excellent. And I do want to highlight that we're really at this amazing inflection point that we're all witnessing, where all of this genomic testing and risk stratification that I was talking about is part of what we call the fourth industrial revolution. So if you think back to the previous industrial revolutions, we're now going through a bioinformatics and computing industrial revolution. So genomics is a part of that. And so I think in terms of that question of future generations, I think it's looking really bright in terms of, let's say, I'm gonna start predicting that maybe 20 years from now, genomics is much more mainstreamed. And so you have the option of seeing these really important risks as well as polygenic risk at different points in your life. So things that are important for your care in childhood, you know about right at birth. And then, maybe at age 20 and then when you're starting to have kids, and then at age 40 and 50, and there will be different opportunities to just have, genomics feed in to your risks and to your health recommendations. And so I think future generations are going to really take advantage of that, as well as gene therapy and ways that we'll be able to modify, any of these mutations. For right now, I think, again, what I'm focusing on is I have essentially all the ingredients that I need right now to start to identify the full iceberg as opposed to the tip of the iceberg, which is all that U.S. healthcare is able to find right now, is really just a tip of the iceberg of all of this hereditary genetic risk. And so we really need to just put it together with the logistics and the operations in terms of, of really delivering it, because, all the pieces are there, but it's really brand new, especially for U.S. healthcare to, to deliver it across the full population in a really equitable way.
Great, thank you. So if you're considered high risk due to genetics, what steps can you take to follow, or what steps can you follow to manage or lower your risk?
Yeah, it's a really, really good question. So again, after you've accomplished all of that of actually getting this information back to a patient and their doctors, what we have and a number of other organizations have built out is what we sort of think of as a multidisciplinary program. So you're starting out with our expertise in genetics of getting the information that you need, having analyzed your particular history and against your family history. So we say like your pedigree is your family history and all that information. So once we get to the genetic, conclusion, and often it is with a positive, result, but sometimes we have to make a diagnosis even even not in with the advent of a really clear result like that. What we do is work hand in hand with the specialties you'll need to follow up with. So for example, if you do have a higher, so high versus just intermediate or average. So if you have a high lifetime risk of breast cancer, we connect with breast surgeons who are expert in that hereditary risk and work hand in hand with people depending on their values and their preferences around the options for starting more intensive screening than the typical general population mammography and exams. So more intensive and more frequent imaging and exams, as well as option for even risk-reducing surgery. So we say risk-reducing bilateral mastectomies, or we used to say, preventive or prophylactic, but risk-reducing is the new term that we use for actually removing the breast tissue before you run into, developing that cancer. And so we have that program where you're having that really crucial kind of first interaction, but then you're following up, over honestly, typically entire lifetime. Sometimes, especially for breast cancer, it starts to kind of taper off, maybe around age 75, just because other things kind of start to, maybe move in a little bit more in terms of your overall health picture. But you're working with that program for a really long time. So we would consider that to be the best practice, as opposed to a disconnected kind of a care path with like your primary care doctor and then occasionally getting to breast surgery. We would say that a dedicated multidisciplinary program would be the sort of the best in class.
Yeah, I think I think that's great. I want to circle back to some of the points that Christine made towards the end of her talk.
Yeah.
Which is that if you are at increased genetic risk for developing cancer or breast cancer, then things like, as Leslie mentioned, perhaps more frequent screening might be implemented, but also these other factors like thinking about alcohol, being more physically active, et cetera. Those are things that, they're good for everybody, but they're probably things that one might want to think about, more specifically, because you are at a higher risk generally, genetically, and those are still going to be, work to lower the likelihood that you're going to develop breast cancer or other cancers. Mm-hmm. So I think working hand in hand with these lifestyle changes, along with the integrated multidisciplinary care Leslie talked about. So. Yeah.
Thank you. Can you expand upon some of the implications from the Pathways study and what it means for breast cancer prevention and treatment?
So I don't know if Christine wants to take that, but the Pathways study is a study of I think, as anyone who's participating in it knows, is a study of women who've already been diagnosed with breast cancer. So it's less addressing questions about breast cancer risk or prevention per se. And as Christine mentioned, we have been looking at some of these polygenic risk scores, for example, that may predict outcomes in the Pathways study cohort of women. And as she also alluded to, we have seen that these polygenic risk scores do seem to predict the outcomes for which they were developed, like the fracture risk. This polygenic risk score of hundreds or thousands, I'm not certain exactly how many SNPs, these polymorphisms in the gene are included in that particular score, but that score is highly predictive of whether people are going to develop fractures, particularly after being on aromatase inhibitors, which are known to increase the likelihood that you're going to develop fractures. So we do see these types of relationships so far. They're not directly translated yet into clinical implications, but we are seeing that there are these associations. As Christine also mentioned, we had identified this particular gene or polymorphisms in this gene, the UACA gene, which appears to be involved in metabolism of certain chemotherapy agents. And so it does seem like there may be some relationship there, but again, that needs to be replicated in beyond what we've discovered before. We can really say for certain that it has sort of the clinical significance of something like BRCA1 or whatever. So.
Thank you. So we also have a question. Do any of your studies look at genetic factors of recurrence, or do they all focus on initial diagnosis?
Yeah, so just reiterating the Pathways study, this is actually looking at, sort of what happens after breast cancer diagnosis. And so that UACA gene finding, for example, which again, I want to underscore that it does need to be replicated before we can really say for certain that it will be important. But it was a pretty strong signal that we were able to identify in terms of looking at the likelihood of recurrence and survival in Pathways study women who all have breast cancer. So.
Thanks. We have another question about whether more frequent screenings might be, or are recommended. So is there a link between greater frequency of imaging and cancer development?
I think well, okay, it's sort of a two-pronged thing, interestingly. Regular mammographic screening, breast cancer screening, is recommended because it does help with early detection of breast tumors. And of course, the age at which the screening starts, generally is recommended around 50, and perhaps with family history or genetic risk, it could be early at younger ages. And then the frequency of that's recommended does vary. However, mammograms, very low radiation exposure, but it is radiation exposure. And as Christine mentioned, the radiation exposure does carry some risk of cancer. Now, in the context of breast cancer, it really seems like it's the radiation exposure earlier in life that carries the highest risk rather than that you might get at age 50 from a mammogram or something like that. But there is a slight, sort of increased risk. However, it's vastly outweighed by the benefit of getting the earlier screening. Or the earlier detection through screening, I should say. So definitely, I mean, those recommendations are well thought out and have thought about these competing sort of considerations. And yeah. So it's appropriate to be concerned about excess radiation exposure, but on the other hand, as a medical procedure, really has been shown, in various studies to really benefit in terms of breast cancer early detection and better survival if a breast cancer is detected, et cetera. So, yeah.
So is there any genetic link there? I think was implied in the question too.
Yeah, so there are studies that really are looking at sort of whether genetic factors do influence the ability to detect breast cancers through screening procedures. So I think that's the answer is yes, there's a relationship. It certainly influences the recommendation. If you have a genetic risk for breast cancer, it does influence the recommendation of when to start screening and the intervals between screening. So there's definitely that impact. Mm-hmm. The other question is, I guess, if you have if you have screening and genetic factors, looking at them together, does that sort of better predict whether you might develop breast cancer in the near term? And I think there are definitely studies that are looking at that very question. And really trying to develop sort of better risk prediction models, so to speak, that incorporate both mammographic findings as well as genetics and, and potentially other factors like how many kids you've had, other known breast cancer risk factors. So, and age of first birth and some other things like that. So, yeah.
So we have a question. Can breastfeeding reduce the risk of breast cancer even if a person is genetically prone?
Oh, Larry's not going to take that. I will just say, in terms of the genetic predisposition that I work with of the very strong, single inherited mutation, that pretty much drowns out otherwise preventive and beneficial effects of things like breastfeeding. Unfortunately, it's just that it's just an overwhelmingly higher impact than the cumulative benefits of environmental lifestyle factors. Though we do, of course, always say that those things are encouraged or are important, like we mentioned, lower alcohol, physical activity, healthy weight, all of those things are really important. However, when you have a hereditary predisposition, that kind of overpowers a lot of those other factors. But for most people, all of those things add up, and all of those things are important and almost to an equal degree.
Great, thank you. So somebody wonders, are we any closer to finding a gene mutation associated with triple negative breast cancer?
Yeah. Well, so I mean, there's a little concentration in BRCA for triple negative, so it is an indication for getting what we call a panel of multiple genes, which is the new mode of testing. We don't, like I was saying, we really don't test single or a couple genes anymore. We don't just do BRCA 1 and 2, but rather a whole panel. In our case, we typically go with something in the 60s. Other institutions anywhere, up into the hundreds of different genes that they're looking at. And there is definitely a concentration of triple negative being a little more likely to yield one of those, we say like a Mendelian or something that's inherited in that dominant, manner, that kind of a result. But I will just quickly say that, and there was another question just about these results, and a lot of times the results are actually inconclusive, and genetic testing results are kind of constantly subject to revision. So even a quote unquote clear cut positive or negative, I mean, really any of these results are subject to improvements in our bioinformatics and our understanding. And so there are a lot of uninformative results that we get right now, and we have to be ready for some of those changes over time. And so I think that as we learn about more genes, but also just have deeper knowledge of the genes that we do know, I think we will find a little more of that connection with triple negative.
Great, thanks. So we're approaching time, and we'll stay a little bit after to answer questions, but I just want to remind everybody to please take the survey as a follow-up to our call today. It'll pop up if you leave the Zoom, and we understand at time if you need to leave, but those of you that can stay, we'd love to answer some more of these questions for just a little bit longer. We might not get through all of them, but we'll try to get through a little bit more. So someone says, I was diagnosed with DCIS post-menopause, and my mother and older sister also had breast cancer. My gene results were negative for BRCA gene. Is it still critical or essential that my daughter get gene tested when she's in her 30s? And what's recommended for the daughter with such a family history of breast cancer?
Yeah, really, really good question. So our guidelines keep shifting as we learn more, as our epidemiologic understanding changes. And I know that somebody also asked, I could see in the Q&A, just about like, well, what about people who don't even have a family history of cancer? And so all of these things are shifting. So we're moving more and more towards a kind of an agnostic approach of, even if you don't have a family history of a particular cancer pattern, or even if it's DCIS of in situ and not invasive yet, that there are benefits to the testing that have been now, have been proven more and more. So when I hear that kind of a pattern, it could well be in that category I talked about of like a little familial clustering and not as clear cut, depending on the ages and the pathologies of these cancers. It might not be as clear cut, like for instance, a BRCA1 mutation. It might be that it's a number of genetic variants as well as other factors that are kind of adding up in that family. But I would say, yeah, so there's the benefit to that person who was affected with DCIS, but then like she or he is pointing out, you have then benefits to children who are, and we say like cascade screening. And so first of all, depending on the age of the child now, like I say, this whole paradigm and shift in medicine might catch up to the point where it is actually more routine for children who are unaffected, even, with these, not just hereditary cancer, but other hereditary risks, to have access to genetic testing. So that might be shifting. Also, I always think about how it, depends on that person's other side of the family. We kind of don't want to forget about, in this case, maybe it's the paternal side, may have something important. And what's interesting in terms of breast cancer is that males demonstrate breast cancer a lot less. And so they may be hiding a breast cancer predisposition, whereas their sister or mother or aunt might be demonstrating it. And so you might have to kind of pull in slightly more distant relatives on the paternal side in order to piece that together. But in any case, there might be a benefit for that child to, as an adult, to at least have genetic evaluation and see if testing makes sense just because of all those things.
Great, thanks. So someone asked, what are your predictions for population-based genomic screening?
Ooh, well, this is all I think about. So pretty much all day, every day. So remember, I pointed out that what I'm hoping is that first of all, I mean, the cost effectiveness and the quality improvement is already established. So I was saying all these tools are in place, the effectiveness is already established. So now it's kind of a matter of the operations catching up, as well as what I was also talking about of like the bioinformatics. We're kind of a little ahead of ourselves with the technology in terms of we can test a lot more than we can interpret. And so I run into this every day where I do this very advanced testing, and then I get these variants back that are currently of uncertain significance. And we literally don't have enough informatics on all the DNA variants out there to even, decisively interpret all of them, which is really not useful for anybody. So the informatics has to catch up. All the operations and all those, pillars of all those pieces have to catch up. But I think I would love for it to be maybe modeled after things that we have really good experience with. For instance, newborn screening. We have a breast cancer tracking and screening program in Kaiser Permanente. So we have experience with population screening. And, when I use the word tracking, it maybe doesn't have like the best, connotation around that, but I mean, really warmly following up somebody's care to make sure that they, either they may have access to sort of, a little more specialized care. Because if you do all this testing, and you don't, effectively follow people up, then it's all for nothing. So I always think about that kind of ongoing care follow-up. But I hope that it can, that it can be modeled after those kind of really strong population screening types of, approaches that we already have and have really good outcomes and good experience. And they're always, of course, evolving too. But that we have a lot of that experience and infrastructure, and we can really just adapt it.
Great, thanks. Someone asks if you can report any specifics from the studies about HER-positive breast cancer.
Sorry, about which breast cancer HER2 positive?
positive.
So I will say that most of our analyses do take into account, sort of whether people are, HER2 positive or negative, ER positive or negative. But I'm trying to think if there's anything specific that comes to my mind. Christine, I'm not sure if there's anything that comes to your mind at this moment. Yeah, I we'll have to probably get back to you on that. So, unless Christine can pick up something. Yeah.
No, I can't. One thing about observational studies, epidemiologic studies, is you need very large sample size. So then when we start getting down to smaller numbers, like only women who have HER2 positive breast cancer, it's a lot more difficult to really be able to see any associations because you don't have the same large numbers.
Yeah. Yeah. I will say, just in a sort of a related thing, we recently did publish a paper looking at what tumors that were classified as HER2 negative, but in fact, within the HER2 negative population, that's sort of deemed clinically HER2 negative and therefore would not necessarily be receiving trastuzumab as a treatment. There are some people who actually have a little bit of expression of HER2 in there, and we did an analysis that basically compared those with a little bit of expression among those that are clinically classified as HER2 negative versus those who didn't have any expression of, and they do appear to be a little different, and there does appear to be some benefit for being able to distinguish between the two. So anyway, that's not the same as asking about the HER2 positive, but it's sort of related, I guess. Thanks.
Thank you. Well, we're about time to wrap up, and I think we answered most of the questions. So I apologize if we didn't get to yours, but we do need to move on to other stuff now. So thank you everybody who attended, and thank you so much to the speakers and panelists. Bye.